Good morning, everyone. Bob Ravenscroft, Vice President for Advancement at Bryan Health for our October 20th press briefing. We have Dr. John Trapp with us today. Dr. Trapp is our Vice President of Medical Affairs and a pulmonologist here in Lincoln. He'll address something short and then be available for questions. He's really plugged into the network of some of the conversation that's happening in the medical community throughout the state. We'll start with our stats. Our midnight census was 512 patients. We have now administered 27,394 tests through Bryan, resulting in 3,235 positives. Right now, we only have 101 pending tests, and 96 of those are from our urgent care, over the weekend and on Monday. So great turnaround time. We have 47 COVID-19 patients that are inpatients in Bryan Medical Center right now. And I think you'll see something interesting and somewhat concerning to us going on here. 16 of those are from Lancaster County, and 31 of those patients, of those 47 inpatients, are from outside of Lancaster County. So what's happening in rural Nebraska is certainly some concerning spread right now. Of those 47 patients, only 5 of them are on vents. 3 of them are from outside Lancaster County, and 2 of them are from Lancaster County. We have no pending patients in-house at this point in time. Out of those patients, 10 of them are in our ICU, 11 in progressive care, and 26 in general care. Related to the directive health measures, there's 4 kind of points I'd like to make before we turn it over to Dr. Trapp and then open it up for questions. The first point is Bryan has been and remains committed to accepting all COVID-19 patients needing a transfer for advanced levels of care and treatment. Since March, there has been one occasion with one patient at a moment of high census where the physician from the smaller community was unaware the patient was COVID positive, and unfortunately that patient was transferred to another hospital in Nebraska. Otherwise, we have and will remain committed to accepting all COVID-19 patients. I think it's important, again, there's a distinction between denials and delays, and that was really a delay and some uncertainty around the patient's status. Second, we are committed and have a responsibility, some would say a moral responsibility, to care for patients needing advanced care or life-saving procedures and treatments. Kind of a rigid 10% vacancy metric when many patients throughout the state depend upon us, many physicians throughout the state depend on us. Well, again, we're not going to turn away these patients when there are beds available. We do have plans for standard care and surge capacity. We've requested some clarification from the state and are submitting some plans to them. And I got to say, the state has been really, really good to work with. They're working with Bryan, Nebraska Medicine, and other sizable systems in the state to make this workable. And it's important to understand we support the governor's directed health measures. But as we discussed in past briefings, the rigid 10% is a little of a sticking point because inpatient census is literally an hour-by-hour fluctuating metric. It's different at midnight than it is at 11 a.m., that it is at 1 p.m., that it is at 5 p.m. Equally important, I want everyone to know the state has been very collaborative, and we do anticipate adhering to the 10% guidance through a combination of our regular staff beds throughout Bryan Health, and this would include our system hospital in Crete. It could potentially include Merrick if need be, but it also includes our waiver beds. The latter is beds such as rehab, pediatrics, overflow units, and our doctor's outpatient surgery center. This is not new. Bryan, throughout this, has implemented all of these except for the doctor's outpatient surgery as capacities have fluctuated up and down. And, of course, this is in the plans requested, and that will be submitted to the state. The fourth point, in advance of the directed health measures that were just announced, we've been very careful in regulating the percentage of our elective surgeries that require overnight stays. It's encompassed in our surge plan. It's been discussed with our surgeons or is being discussed with our surgeons. And then certainly there's some nuances in the definition of electives, and Dr. Trapp will cover that a little bit. The last two things, I would just implore everyone to heed the governor's advice. Even though he has stopped short of a mask mandate, he has been very clear he's counting on Nebraskans to do the right thing. And that right thing, even articulated from his podium, is to wear your mask, avoid crowd sizes, distance when possible, and wash your hands. So our position's been very clear. We are supportive of universal masking, but we applaud what he's saying to Nebraskans, and that's to do the right thing, and he's been very clear on that. Then last thing I guess I would like to add is, if there are people, and occasionally it's waned off a little bit, but if there are people interested in finding ways that they can help our staff out, please contact the Bryan Advancement staff and they will connect you with the right people. As we've been at this now for a good 6 months, it's grueling for the staff. There's no denying it. They are the ones that are there, bedside, wearing their pappers, missing vacations, watching people pass away, dealing with patients with extraordinarily long cares, being that conduit with families. They are heroes in my mind, and anything that we can do to support them is helpful. And we're requesting ideas and offers of assistance from the community to let our staff know that they are rock stars in our opinion, and I believe the community as well.
Well, first of all, the things that are going on across the state are certainly concerning. As we modeled this pandemic, we see numbers increasing across the state with regard to positive testing. We're seeing increased numbers of hospitalizations. We're seeing increased use of ICU beds. Within Lancaster County, numbers have been slowly creeping upwards, but we're certainly seeing higher rising cases within the rural communities. Right now, the rural communities are doing a great job with regard to the hospitals. They've been able to keep those patients within their communities and are doing a great job in managing those patients. I think we've seen some of the highest numbers of COVID-positive patients within our rural hospitals. I believe numbers of 60 to 80 plus. The important thing, as Bob has mentioned, when those patients are able to be managed at those acute care hospitals and local hospitals, that's fantastic. However, at times they may need higher levels of care, and Bryan wants to stand ready to accept those transfers. So as Bob has said, we have developed a surge plan to really follow the directed health measure put out by the governor. We support that we're going to need those beds. The modeling suggests right now, as numbers spike, that we should continue to see a surge up over the next 2 to 3 weeks, where we're going to need increased bed utilization, increased ICU utilization. So those are important things. Those patients need that care, and they need it at the time that they need it. So we're going to look towards whatever we can do to maintain an adequate supply of beds and a bed availability to accept those transfers. And Bryan remains committed to accept those transfers whenever possible. We also realize we have a commitment to our community and to the surrounding communities with regard to other types of acute care needs. And we remain committed, again, to taking care of all of those acute care needs that are referred to Bryan Medical Center. As part of the directed health measure, there's also a discussion with regard to elective surgeries. Now, that's really an interesting topic when we think about elective surgeries. Really, what is an elective surgery? Many of our cases, when we look at that, 60% of what you might consider elective cases really never affect our census. They come in and are discharged out of the recovery area the same day, so they never spend a night in the hospital. The other 30 to 40% of patients that require an overnight stay or a longer stay, some of these cases may include cases where patients may have a lung nodule or a lung mass that needs to be resected, or a colon cancer. Those are considered elective, but completely necessary surgeries. So we want to be thoughtful with regard to, if we delay those types of cases, it does have the potential for harm for patients. So we're really looking to continue to do those cases. I believe there's a lot of thought that we've delayed a lot of other previously elective surgeries from earlier in the year, and we're seeing really a rise in the number of surgical cases happening right now. And I think some of that is really that pent-up demand to get those cases done, and we hope to continue to do those in an expeditious way, in a timely way, and particularly for those cases that need to be done sooner than later. So we'll continue to work with our surgeons to develop a plan. Certainly elective surgeries or these types of surgeries are part of our surge planning, and we will de-escalate those as appropriate as we see numbers rise within the hospital.
It is real, and we only have to look at our own organization. Standing in this media briefing room, there are people who missed family funerals. There are people who have missed other family events. I'm walking my dog around the same block that I walked it around since March, and we've been passing up, trips and visits with our family. And then on top of that, our critical care staff, they are seeing families, still separated as they deal with COVID things. And they've gone without breaks and vacations for the most part for the past 6 months. So it is very real. And we do understand the community is tired of us saying every day, wear your mask, wash your hands, socially distance. We miss going to football games. We miss the gatherings. So it is real. We know people are tired of hearing about it, but it's truly the time to double down on everything that we know work. And we know these, since the very early days of this pandemic, we know these work. And we do wish people would wear them in greater numbers. Frankly, I was out over the weekend, and Lincoln, where we have the mandate, they've been doing a great job. This community is very, very compliant now. And I think it's interesting that we have 16 COVID inpatients from Lancaster County with over 400,000 people, and 31 from the rural parts of the state right now, where there's less adherence to that.
I think there's no doubt. I think there's a lot of COVID-19 fatigue, whatever you want to call that, and how fatigue can impact each of us. This has been going on for a lot of us since February, March. Certainly we are fatigued with the restrictions that it puts on our personal liberties, if you will, how it impacts our gatherings, how it impacts families, potentially the fear it brings forth with regard to our at-risk patients. So I'm going to say that's really individualized. It's hard to call it a syndrome because I think that means different things for different people. How it affects our providers, there's a sense of fatigue as they continue to see high numbers and the requirement to go through a doffing procedure with patients. It takes longer to evaluate patients. There's that levels of fatigue. Fatigue within families with regard to the restrictions, how your children are participating in schools and what restrictions occur with them, the precautions that you may take with your parents or elderly, or if you have family or friends within nursing homes. I mean, all of that presents with fatigue. We know there's some real medical evidence that this pandemic has really increased risk for depression. I'd probably defer that to my psychiatry colleagues to address better, but those are real findings. It does isolate people, and that isolation can certainly contribute to a sense of personal fatigue, depression, anxiety. So in many ways, COVID-19 fatigue is real, and it can cause both physical and mental health issues. So I think the why people need to be aware, the risk for community spread is real. So as we see numbers increasing, when you go to the grocery store, when you do other places, when we see higher testing positive rates, you're going to have that higher risk for exposure. So again, I think that gets back to doing the things we know about this virus, how it's spread, and what we can do to minimize its spread. And our clinicians and the hospital have continued to remain fully supportive of masking. We think it's the right thing to do. We support the local mask mandate, if you will. We think it allows people to continue to be involved in their community and do things when they wear a mask, when they use social distancing, when you use good hand hygiene. So I think it allows us to remain functional. We've seen that in the hospital. So I think that's the how. I think the why should be obvious as we see numbers rise, but I think the how is been well delineated for us on how we should do that. Interestingly, as we've seen numbers rise, we certainly have seen hospitalization rise, but actually death rate overall for the numbers of positive has dropped. I think there's a lot of factors with that. I think we see younger populations who have contracted the virus. They're certainly at a much lower risk for death than perhaps our at-risk patients. I think our at-risk patients continue to do a great job wearing masks and trying to remain safe. I also think that the medical community is doing a better job, maybe a different job in how we manage these patients. If you look at early on in the pandemic, our ventilator usage was much higher than it is now. So despite the same number of patients, we're using less invasive ventilation. We are finding that other modes of oxygenation, using high-flow oxygen, non-invasive ventilation like BiPAP, are able to bridge many of these patients without having to put them on a ventilator, giving them time to recover. So when you can minimize risk for ventilation, I think you reduce the risk for mortality. I think that would be my response. Overall, death rate is decreasing, not increasing, but just with the higher spike in numbers, that percentage is still there. Our rural hospitals do a great job with regard to, general care patients and even some progressive care patients. We have different resources, different specialists that may be able to assist some of those more complex patients. So as oxygen requirements increase, or if they get concerned that those patients are headed the wrong way, they want to transfer those patients. If they see patients who have multiple risk factors, who are at high risk for declining and require high flows of oxygen, they're likely transferring those patients. They want to do the right thing for each of the patients in their community by transferring to a higher level of care when they see that as appropriate. But I also think they're feeling comfortable to manage some of the patients who have lower levels of acuity, who are COVID positive, who may need lower levels of oxygen, and they're able to watch and wait with those patients and maintain that census within their community. But if the time is right and they feel it's indicated to transfer the patient, we stand ready to accept that transfer.